Dr. Price, thanks so much for being here. I'm sure like people maybe read your bio, but do you think you could maybe just give us like a brief overview about like what you do?
Yeah, sure. So currently, I'm the chief medical officer at Denver Health, which is a level 1 trauma center, public safety net hospital, and one of the major teaching hospitals associated with the University of Colorado. Wonderful place to be. But my background, I've been the CMO for about 5 years. Before that, I was chief of infectious diseases here for 13 years. And really a wonderful career doing that as well. I still do clinical work. I would maintain it's my most important skill and my most valuable skill. And so that's very important to me to maintain that. And I still do research. And of course, I teach as well whenever I'm on service. So that's my job here. I trained at Northwestern. I did medical school at Northwestern, and I did my internal residency there as well. I did my ID fellowship at the NIH with Dr. Fauci, who was my lab mentor. At that time, I was doing HIV immunopathogenesis. Went back to Chicago and kind of moved more into epidemiology, hospital epidemiology, after spending some time doing a microbiology fellowship as a second fellowship. So kind of evolved from HIV into hospital epi and microbiology. And then that's what I came to Denver largely to do, is they really needed somebody with that background, and they needed a new chief of ID. So that's how I ended up in Denver. But thank you for asking, and I'm excited to tell you as much as you want to know.
And so a couple students had questions about your work in public health versus clinical practice. So can
Yeah.
you please like maybe elaborate on your role working with like public health agencies?
Sure. Well, Denver Health is actually a public health hospital with its own public health department. So even when I'm doing clinical work, it's hard to separate your role from public health. But I would say, in general, clinical medicine is, of course, taking care of the individual, which is, to me, what motivates things like more, population or public health interventions, and doing things that really are about policy and preventing illness, and or maybe even doing something like an outbreak investigation, which is something my career has segged into quite often. So I mean, they're complementary, though functionally just very different types of activity and thinking. One is that individual patient relationship. The other is, taking what you've learned from that individual patient and think, how do I prevent that from happening to others? Or how do I prevent this disease from occurring in a population? And so that's what public health is to me. Most of my intersect with public health outside of just my administrative role has really been in outbreak investigations, which kind of the glamorous side of ID, where I got to trot around the world a little bit and do outbreak investigations, try to figure out where they came from and prevent them from happening or stopping the outbreak.
Thank you. Can you tell us maybe what your typical week looks like?
Well, for ID, you've met one ID doc, you've met one ID doc, because most of us have all kinds of jobs, right? And ID is one of those things where you get introduced to so many different types of people and so many roles in the hospital, or so many, in academic medicine, you're doing research, teaching, clinical work. And so everybody's job will be a little bit different. So for me and for the others in the ID division who I work with, it really depends on how your time is funded. So my time now is largely administrative as a chief medical officer. So that's about 70% of my time. And then I have an RO1 that I'm still finishing up. And that's a good 20% of my time. And the rest of it fit into 10%, but more than 10% is my clinical work and teaching combined. So, my week depends on what my responsibility is in, all those different functions. If I'm attending on the clinical service, we tend to do 1 week blocks or 2 week blocks where we'll be on that whole 7 days. But then, beyond that, after I am done with that block, if I'm in my administrative role, it's more kind of a regular work week, long days, but weekends that are pretty much open. Evenings, after dinner, you're on your laptop again. But I always joke that it's any 80 hours a week I want to work. So it's long hours, but flexible.
And what would you say is your favorite part of being a physician specializing in infectious disease?
Oh, the variety. It's so cool. I mean, you don't focus on one organ system. You get to just every organ can be infected by something, right? So you have to know your internal medicine well. And that really was my first love. That's what drove me into ID, was I just loved internal medicine. I loved talking to smart people. I loved the differential diagnosis. I loved working people up, diagnosing people. So that really was what got my interest. And then when I trained, it was the height of the AIDS epidemic. We didn't have heart. 20% of my inpatient service was HIV. And so, I mean, these young patients with complex problems lists that were 20 different things long, and sometimes new diagnoses that we really hadn't even heard of or experienced for very long. So I found that incredibly exciting. And then I liked the hospital. And at the time, I mean, hospital medicine really wasn't a thing when I was training. It was just starting to become a thing. And so for those of us who just liked hanging out in the hospital, ID was the field you went into. Now, of course, there are hospitalists, and the AIDS epidemic really shifted from being an inpatient issue to, thankfully, an outpatient issue.
And then in terms of work-life balance, what is a non-negotiable part of your work and personal life respectively? And then how did you kind of figure those boundaries out?
Yeah, well, I don't confess to figuring out those boundaries. That's a problem. I have not really found that non-negotiable, or I haven't been very disciplined. And it's a mistake. I mean, you have to make time for yourself. You have to learn to say no. I can watch others be really disciplined with their time and say, I'm going to be on vacation from this date to this date. If you have a question, don't email me, don't call me. Here's somebody you can contact. I tried like having somebody answer my emails while I was away, or, delegating that. I'm still trying to figure it out, because, when you come back from vacation, those things are still there. And I don't know, I've never figured out how to, would I rather do a little bit while I'm on vacation and then come back to, a boatload of work, or relax on the beach and knock a little bit of it off? So I don't have a good answer. I'm going to be honest. I actually look to all of you to tell me how to better manage my time and protect my personal time a little better.
Thank you for sharing that. Does anyone have any other questions right now that they want to ask Dr. Price?
I have a question about your training at the NIH. So you said 20% of your patients were HIV, and then what were the rest of the patients you saw? Because I know that it's like a referral center. So
yeah, well, so what I was referring to actually was my residency at Northwestern. At the time I chose to do ID, it was the mid 90s, right before HAART, and it had come out, and then people were being hospitalized. There was TB, there was 20% just bad HIV and stage AIDS. And then at Northwestern, it was sickle cell anemia. It was, dialysis. So, you guys know the population. It's so funny. Then when I went to do my fellowship, all my inpatients were gone. All of a sudden, everybody's on HAART, and I don't have HIV patients in the hospital anymore. And what I was generally treating in the hospital was an occasional OI that needed to be, like toxa, or something that just needed some initiation on therapy, or KS or something, so it really shifted to the outpatient setting. And then the NIH, of course, isn't just ID, it really is an immunology clinical center. So, you know, we had a lot of patients on protocols for treating their chronic granulomatous disease when your neutrophils don't work, and people who keep getting a specific set of infections. Craziest thing ever. Job syndrome. If you don't know what that is, look it up. Hypereosinophilia syndrome that has a very distinct syndrome associated with it, that NIH probably has the largest population of patients who are all under clinical protocols. I had patients who had these like immune deficiencies that made them prone to non-tuberculous mycobacterial infections, you know, incredibly rare infections. People would fly in from all over the world to be treated. We did have some HIV patients who were on protocols for, you know, interleukin 10 was one that we were experimenting with at the time. So it was a wide variety of things. Oh, mastocytosis, that was another one. Not an infection, and actually not really even common in adults. So I was taking care of kids with this immunologic issue that really wasn't ID, but it was still a really incredibly valuable experience. Places
Did you feel like you saw Did you feel like you saw enough bread and butter ID to be like a good clinician, or is it too specialized for like fellowship?
Well, I could not, I mean, you have to go somewhere other than the NIH to really see real medicine. So that's one good thing about the training program. We had about 2 to 3 months at the clinical center. And then the rest of our time we were at Hopkins, Georgetown, George Washington, Baltimore City, a CD clinic in the mid 90s, craziest place ever, heroin capital of the world at the time. You know, so we got a good clinical experience. So not quite as bread and butter, but it was good.
Does anyone else have any questions they want to ask right now? Okay. Oh, Sophia, did you have a question?
Yeah. I just wanted to follow up on your experience in NIH. I was wondering if you could talk about, like, did you have time to do some research during your fellowship, and how was that like?
Oh yeah, I had to do research. I mean, you know, so I did my first year of that clinical experience, which I just described. The second year, I had to pick a lab. And I picked Dr. Fauci's lab. I was told actually at the NIH, they want you to do bench research. So if I wanted to go do epidemiology up in Baltimore, that was one thing I wanted to do. Cliff Lane, my mentor, said, no, we need you to get experience in the wet labs. This is the NIH, for God's sakes, and we're going to train you to be a scientist, and you're going to know how to pipette when you get out of here. So mission accomplished. And it was really, I mean, I'm glad I did it. It was a great experience. And I was able to translate so many of those lab skills into my future research. Even my R01 today, I still pull from that experience. And then just the experience, just the process of working with Tony Fauci and being able to just have a project and try to solve it in the lab was incredible. The NIH, you know, you don't have to write a grant. If you have a question, you just answer it. And I would say, okay, I want to know if people after influenza, when their receptors are all activated, if they're going to be more likely to get HIV infection or not. I don't know why I had that question, but I did. And so I said, okay, I want to get a patient's cells with this CD4 count, you know, within this period of a recent influenza infection. And I'd put in my order, and the next day there'd be cells, or not next day, but like a week later, there'd be cells in my bench for me to go ahead and do whatever I wanted. So it was a great privilege.
So there's some other questions about your training, and I know you touched on this a little bit, but one question was, how did you find your niche in medicine, and maybe more particularly within infectious disease? And also, like, were you considering any other specialties when you were in medical school?
It's so funny. When I was in so in medical school, I had no intention of going into medicine. I was going to do something like radiology or something, surgery maybe. I did medicine last, as my very last rotation as a med student, and I loved it. It was the best. I just loved talking about medicine. So ended up doing that. At the time, our structure was 11 ward months. I had one elective. It was ID. I liked it. So, and it seemed to fit with my general interest in medicine, that it was just broad based, it was hospital based. And I guess, I found my niche really in my interests, and they evolved based on what was interesting. And, if you kind of have a broad base of skills, you can evolve, you can do what your passion is, which may change over time. So, again, what really got me into ID partly was just witnessing the AIDS epidemic, growing up in it, and having that curiosity from the patients I took care of during residency. And that drove me to the path of HIV immunopathogenesis. But then when I went to do a follow-up fellowship in microbiology, because I wanted to round out my skills in the micro lab, then it was really cool it was interesting to see all these resistant organisms that, in the micro lab, you were the first to know. So, then I was like, well, why is this happening? And that kind of drove me into a different niche, into epidemiology, and why are these bacteria getting resistant? And I'm going to study that, and I'm going to try to figure out these outbreaks, and, and so on. And then, emerging infectious diseases, it's, whether you like it or not, that's going to be a niche for any ID doc. And so, that ended up being in my role as the chief of ID at a public health hospital, and the mayor calls and they want a briefing on H1N1 or bird flu or whatever the emerging infectious disease is. That drove me to a new niche. Start reading about it, you get interested. So, while you want to stay somewhat focused, and that is the advice most of us are given in a successful career, you also want to be able to be responsive. And I look to my past mentor, Tony Fauci. He's an immunologist who then, tackled the HIV epidemic and is now shepherding us through COVID. And so I think he's sort of done it the same way.
And do you have any recommendations for a student who's interested in doing infectious disease to do during medical school?
Oh yeah, derm, do derm, because all the rashes. I mean, I'm still not that good at rashes. I wish I had done derm. So that's a good one. Ortho, I mean, you got to know what they do in the operating room, and then, that's all. You just need 2 weeks with them, and then that's all. But you will be consulted a lot by ortho and neurosurgery. So it's good to sort of have perspective on what happens in the operating room, who the people are consulting you. And make sure you have some familiarity. If you don't get the chance to do the rotation as a med student, when you become an attending, you can always, take half a day and follow somebody around. Even I've been to the OR with some of our orthopedic surgeons just to try to understand them better.
And what are some of your favorite memories from Northwestern medical school and residency training?
Yeah. I loved the camaraderie of the other students and trainees. I mean, just this shared passion for learning and just, patient care and the intellectual conversations. And I loved being on call with my team. It sounds so funny, but I actually loved internship. I liked being on call because it was like being at camp. I mean, we would, we'd all be admitting, and then around 2 a.m, we'd be done admitting. Night float would come in, and we'd then go to the cafeteria, and there'd be this lady down there that would just like save all this food for us and feed us for free. And we'd sit and, just laugh. And I don't know, it was fun. It was work that was fun, and it was stimulating, and it was really a privilege. And then Chicago in your 20s. I mean, no better city in the world.
That sounds really nice. I know we're probably all looking forward to the end of the pandemic when we can, kind of start making those memories as well in medical school.
I bet you are. Yeah. Really, yeah.
Anyone have any questions about Dr. Price's training or anything?
Dr. Price, do you mind talking about your journey into leadership a little bit and what prepared you for
Yeah.
that and what you would recommend for young physicians thinking about leadership?
Yeah, I guess I just, be present. I think, one of the great things about ID is you get to interact with everybody. I mean, that, it's such a frequently consulted specialty that there's very few people in the hospital who don't know who the ID docs are. And so you're out there, you're interacting a lot. You're being called on for, quality issues, surgical site infection prevention, antibiotic resistance, emerging infectious diseases. And I really think it was those experiences that, really exposed me to so many parts of the hospital, so many people in the hospital, and then administration for all of these new issues. I became kind of known to the people who were leading the hospital at the time. And so when these roles became available, I would be invited to apply. And, you just kind of gain credibility through your day-to-day work. I never really thought that I would end up going the hospital administration route. I really thought I would be, go the, division chief, department chair, maybe dean route. But just the way it worked out, the timing and the opportunity available to me, I made the decision that this is something that I can really make a difference in and I can have impact on. I have a seat at the table, and you still get to interact with all these smart physicians and healthcare providers everywhere. So all the things that I fundamentally enjoyed about ID and medicine, I still got to experience in administration. So I took the opportunity, and I think I'm glad I did it. People, others before me have said or warned me in this role that, when you're doing clinical medicine, you're doing ID, every day is just an amazing day. You're seeing a new patient, you're fixing something, you're teaching a resident, and you come home and you have all these good days. In what I'm doing now and in leadership, sometimes it's not good days, but maybe good months and good years. There are hard days. And so you have to look at it from a much broader perspective.
Thanks, Dr. Price. On that note, could you sort of explain a bit more of what like a CMO does? Because personally, I'm not really familiar with what they do.
Yeah, sure. It's different at almost everywhere. It's so really your fundamental responsibility is over the quality and the delivery of the medical care. So you are the physician who's in charge of really everything medical that happens in the hospital. In some institutions, it's a more passive role where you don't really supervise anyone. You just sort of review a lot of protocols. You're in charge of the medical staff office. In other settings, you're really a lot more involved in the operations, and you may supervise the department chairs, which is my situation. And you may supervise other areas. So I also am over our public health department and our research and education office. So it just depends. It's very different from institution to institution, but that is the fundamental responsibility is you are on point for everything medical that happens at that hospital. And that's why you need good people like Dr. Thurstone who know what they're doing when they're running their departments, because that could be a very hard job if you didn't have that.
Nathan, I'm glad you asked that question because Dr. Price has a very big job at Denver Health in terms of her responsibilities at that institution.
Yes, thank you. That was really helpful.
I had to ask the same question when I applied for it 5 years ago. So.
So we probably couldn't have a conversation with an infectious disease physician nowadays without talking about COVID. So could you maybe share about how your experience or training with infectious diseases has affected or informed your approach to the current pandemic?
Yeah. Well, first of all, I noticed that, COVID was very scary. It was new, it was scary, it was, uh, a lot of people just really didn't want to, were just very frightened to come to work. I noticed that the ID docs seemed to be a little bit less phased by it. I think that we're trained to, trust in infection prevention, trust our PPE. And so COVID has underscored for me that, yeah, those things work. Those simple things that we do in normal practice to prevent the spread of infection really do work when you have access to them. And I think it's highlighted the importance of those very everyday simple interventions. We all had a lot of hope in all the drugs that were being in clinical trials and hoping that we'd have our magic bullet. But we had some good data with remdesivir on shortening hospitalization. We had some data with dexamethasone and decreasing mortality, but they really weren't that wasn't the main intervention. The main interventions were really just basic infection prevention, social distancing, wearing your mask, protecting yourself when seeing patients. And simple things work sometimes.
And maybe besides, putting your PPE on and off, has the pandemic changed anything else in your daily practice?
Well, a lot more Zoom meetings. But, I think we've revisited everything, right? I mean, visitors, should we ever go back to having a free for all for visitors? I mean, hospitals are places that there is a lot of opportunity to transmit infection, and it's a special environment that probably should be a little better controlled. So I don't know if we'll ever go back to the same visitors guidelines or lack thereof that we had pre-pandemic. I also think that things that we do, just basic seeing patients. I think about, again, the AIDS epidemic. There was a time that nobody wore gloves when drawing blood. Surgeons operated without gloves in my lifetime. And it was the AIDS epidemic that really changed, the use of gloves. We can't even touch a patient now. It feels weird if you don't have gloves on, but that was not always the case. So I think we also will make it routine that we may be wearing a surgical mask for every patient encounter, even well after this is behind us. When I first experienced the SARS epidemic in Toronto, the original SARS-CoV, that is one thing that impressed me when you read about how the first case of SARS-1 got into Toronto. It was a family medicine doc seeing a guy who had just flown back from the Hotel M in Hong Kong and treated him for symptoms that sounded like heart failure. And he ended up dying of SARS, being the first patient in Toronto to die of SARS. And then about 10 days later, the physician died of SARS. He didn't know it at the time, but figured it out as that outbreak and epidemic spread. And I remember thinking at the time, wow, I mean, why do we ever see patients without, just let our guard down like that? And I wondered if we would ever see a change. I think after this epidemic, I don't think you're going to go to a doctor without a mask, or at least the doctor will be wearing it.
But what do you think about like patient interaction and like, I don't know, isn't there supposed to be something that you get by like interacting with patients?
Oh yeah.
With expressions?
Well, that's the other thing is that we're going to see a shift to telemedicine. That came as a, huge during this and still is, and it is here to stay. So yeah, it's going to change. It's going to be very different. You're not going to have that same face-to-face interaction, I think. And so we're going to have to figure out how to make that connection in different ways, both for the patient and for our love of it.
And I think that's such a great point. In psychiatry, we rely on the mental status examination. If you have a mask on and then if you have a face shield on, it's very difficult to read all those facial cues and expressions. And so it's going to change our mental status exam fundamentally moving forward.
Yeah, I know. Yeah, Chris, I know your patients really don't like those face shields.
I don't think the physicians do either very much.
Right. Well, maybe there'll be a day where we can ditch the face shields, but I think the masks are here to stay.
Hi, Dr. Price. Thank you for speaking with us. I wondered, so I'm from New Mexico and I know Sophie too. And I guess I wondered, you talked a little bit about some of the disease profiles that you saw working at NIH and also at Northwestern. I wondered, and traveling around the world, you've seen Ebola, you've seen some of these different diseases. There's kind of a unique, I don't know, do you feel like there's a geographic influence in the epidemics that you experienced there in the Southwest? I mean, I remember people being surprised that we'd seen plague, and that's something that happens.
Oh, totally. I mean, so we don't have Lyme disease in Colorado. I don't have to even think about it. It's awesome. I mean, unless, they've traveled. You just don't see it like we did when I was training out east and even a little bit in Chicago. I mentioned sickle cell anemia being a big part of my census in Chicago. I've seen one patient with sickle cell anemia here in my career. It was about the third year I was here. And it was, this anomaly, and I was attending. I'm like, oh, I got this. Well, the patient died. I mean, it was awful, but yeah, we don't have sickle cell anemia here because you don't survive, at least if you're, full trait. So, it's not only infectious diseases, you see just different things. Yes, we do see plague, we see hantavirus. Gosh, I've seen brucellosis here, crazy stuff. And yet in Chicago, you guys have fun things like histo and blasto and all the good ticks that we don't have here. We do have Colorado tick fever, a little of that, not so much Rocky Mountain spotted fever. The big one is the relapsing fever that we sometimes see from the mountains, the tick-borne relapsing fever. But yeah, definitely geographic influence for sure.
Antonia, that goes for addiction psychiatry as well. In Chicago, I never saw a patient with methamphetamine use disorder. And here in Denver and probably in New Mexico also, it's our ERs and inpatient units are just overrun with methamphetamine use right now.
Yeah. Yeah, and out east, I saw a lot more malaria because there were so many more travelers, like in the DC area. When I'd be on call for Georgetown for whatever reason, God, every weekend there was a malaria case. So, I rarely see that here.
Hey, this might be kind of random, but I was just gonna ask, what was it like working with Dr. Fauci and seeing him now being kind of the face of medicine?
Oh, it's weird. I mean, so, the thing that I remember most about him, a couple things. So first, he loved his MD trainees. He so favored us. I loved it, and the PhDs hated us for it. But I got to meet with him every week in his office, and my meeting with him was right after his White House briefing. So it was during the Clinton administration, and he'd always be a little bit late, and I'd sit in his office, tiny little office in the building, in the clinical center, tiny little office, and but all these pictures of him with Madonna, him with Bono, the Pope, everybody, and you just sit there like, wow. And this is before COVID. So he was, he was quite a force. And he'd come in and he'd tell me about his White House briefing and, who he thought was the smarter one, Gore or Clinton. And, so he was very approachable in that way. Fun guy. Favorite movie is The Godfather. The way he wants to die is with a glass of Cabernet on his hand and just falling over. So and I heard him quote in an article recently, his favorite movie being The Godfather. So that's a diversion. As far as, the teaching, one of the big things was communication. He was obsessed with his PowerPoint slides because he always said, and my job might be to spend a week making him a slide if he's giving a talk on something. And, he was so particular about how he presented work. He was so, he wanted to make sure everyone understood it. And he always said, well, I need this slide to make sure it encompasses this because somebody might walk in 20 minutes into the talk and I need them to know what's happening. I mean, he was obsessed and he rehearsed his talks. Everything he said, he rehearsed. So you see that. I mean, you see how effective all of that concern and work on communication is and how we so needed that during this pandemic. And always very grounded in the science, always trying to stay neutral and non-political. He was, he really respected physicians. We are his people, and he really went out of his way to mentor us in lab science. And I remember him saying once, I'd come with an idea. He's like, that's not an original idea. There are people who are actually seeing real patients out there. Their doctors are seeing real patients out there who've thought of this 20 times over. But the difference is you're here and you can do something about it. You can figure it out for them. So always thinking about what that frontline doc is going through and wanting to solve it. He truly is an amazing person.
I wonder if I could ask you, I know you've worked through, I appreciated, I worked in HIV for a few years, and I really appreciated the way that you talked about really the incredible difference that happened within a decade, not that we're out of the HIV epidemic, but just kind of a huge kind of the emotional meaning of that. Which says a lot to us in the middle of this epidemic, right? That there are such incredible scientific and public health advances that can be made and that change people's lives. But you've also worked through, I don't know, you talked a little bit about Ebola, and we now have an Ebola vaccine. We're in the middle of COVID and responding to it, and we now have some hope on that front. I wonder if you wanted to speak at all about kind of one of those, some place that there was meaning for you or finding hope, I don't know, in the middle of some of this where you're seeing, some really difficult experiences of patients, really just suffering through something, and how you find hope if you're in the middle of that.
Yeah, well, I mean, the most immediate experience is COVID and finding hope in, every day going to the medical literature and finding something new that could help us treat this disease. Think of it. We had no information. It showed up. We had a little lead time, but it showed up. And, we actually activated our incident command in the hospital, and we had an army of med students who were pulled off clinical rotation to help us. And so their job every day was to do a lit search and tell me something new about this virus. And we would send it out to all of our medical staff. So even simple things like different presentations of COVID, hey, there's this thing called COVID toes, look for it, guys. Or, hey, guess what? We don't have to, this paper says we don't have to intubate everybody who's hypoxic. And, there's this thing called permissive hypoxia that actually is better for patients. Following the hydroxychloroquine research and being able to pull back from that when we were using it based on rumor, essentially. So every day there was something new out there, and that gave me hope. It made me feel some power over this thing. And I had many other of our physicians say the same thing. It made you, it's that knowledge is power, and just like, okay, one more day, I know more about this and we can get over it. And then, now here we are with a new technology, 2 new vaccines with a brand new technology, and a third about to be distributed really in the span of a year. So that's also hopeful.
There was also another question about what roles, if any, do you foresee for high throughput sequencing in infectious disease epidemiology?
Well, I think I see a real trend first to viral research, but upper respiratory viruses, because I think we now appreciate that even these, even a coronavirus, the previous cause of a common cold, we had very little understanding of that, and yet it was this common infection. I think whatever tools we have to better understand spread, epidemiology, evolution, mutation, we're going to end up using it. So yeah, I see these things being used more. I mean, we've used it in some bacterial outbreaks, and we still have to define how best to interpret it, but I see there will be a need to use those tools to the best of our capability to better understand transmission and the evolution of these viruses, for sure.
And someone had a little bit of a more specific question. How did you start collaborating with Colonel Ruck?
So I'm not sure. Let's see. So is he? I don't remember that person. And I did do some work with the DoD, and maybe is that whoever asked that? Can you tell me where you gleaned that?
It was in your biography when they emailed, and I just asked because I'm in the Navy, and so I'm really interested in DoD partnerships with academia.
And so I don't know if it was specifically Colonel Ruck, but definitely, and I still have collaborations with the DoD. The DoD sponsored one of my first grants in rapid diagnostics for bacterial infections, and they were really interested in all that resistant Acinetobacter that they were seeing in Iraq back, Chris, which Operation Desert Storm, or one of those things, right? So, that they were really interested in making sure that they were protecting our military from these infections. And so they gave me funding to figure out how to more rapidly diagnose the resistant infections, and particularly Acinetobacter in our wounded warriors. And there's similar interests. Right now, I'm talking to the Air Force about we're one of these, we're a special pathogens treatment center at Denver Health. We're one of 10 in the country. And so the Air Force is very interested in how we can help them when we have, our military somewhere in another country. They need to be airlifted back. How do we get them to Denver? And what protocols can we practice to make sure that we're taking good care of them? So, there's lots of great opportunities to collaborate with the military. And of course, everything they do is for their, military, as it should be, but it's also very relevant to the general population. So I love those collaborations.
And just to clarify, it was not in the part of your bio that you shared with us, Dr. Price, but it was something that I supplementarily added. So I hope I had accurate information. But
and I'm sorry, maybe there certainly were different wonderful people I collaborated with. I just don't remember that name.
I'm sure.
And so, Dr. Price, what has been the most challenging part of your career?
Oh, that question you asked about work-life balance. That, as you can tell, has been a challenge, still is. And it's hard because I actually like my work. And so I do like to work a lot. But I also like my family and they need me not to work a lot. So trying to figure out a better balance.
Is there anything that you wished you did differently in med school?
Yeah, I have such respect for my fellow physicians and having been able to train with, think about it. I mean, all of you are just incredibly talented, smart, accomplished people who got to this amazing place. And I got to spend 4 years with my med school class. And I'm sad that I'm not in touch with all of them. I mean, we got very close, but it's sort of like we all scattered. And I don't know. I wish I would have spent more time with them. I wish I would have maybe just given up a couple more nights to just enjoy Chicago with some of my med school classmates. I wish that I had made more of an effort to keep in touch with them. I mean, really, it's really an amazing group of people. Same with my residency class. But it's easy, we all move around, we all scatter, and, try to keep in touch with these people you trained with.
So I think that covered most of the questions people asked, before this session, but does anyone have anything else that they want to ask Dr. Price?
Dr. Price, do you have any questions for the students? Do you want to know anything about the medical school, the current curriculum?
Yeah.
They do for wellness, any of those things?
Yeah. Do you guys have to sit in a room for 8 hours a day for 2 years anymore? Because I did.
It's good. One of the benefits of Zoom school.
Yeah. Well, but so when it's pre-COVID, do you have a lot of just lecture time, or is it mostly hands-on and experiential type of learning? I know it's evolved a lot, which is probably a good thing.
That sounds like an opportunity for an M2.
Yeah, exactly.
Excellent.
So pre-COVID, we would have lectures in the morning, and then afternoon is more small group based hands-on learning. So problem-based learning, group-based learning, fake clinics, and real clinics.
Okay. And do you do a lot of outpatient work in your curriculum? I mean, it sounds like you do clinic or you have mock clinics, but do you spend time, I know you spend time in the hospital, but do you also go to the outpatient setting in medical school?
So they've recently been switching everyone from IP, which is where you would essentially be shadowing in the hospital every other week, to everyone being in clinic 1 day a week, every other week, in a longitudinal way. So I go to the same primary care clinic. So it's so cool because I have patients who I'll see and then I'll see them in 6 months and I'll see the same patient, or people I called during COVID to check in on, then I'll see them in clinic. So it's longitudinal and you do that all 4 years.
That's great. Yeah, we actually have a really neat program like that too in Colorado, our longitudinal curriculum. So yeah, it's really different. I mean, when I was training, it was years 1 and 2. I mean, just 8 to 5 every day lectures, and then you'd have anatomy lab somewhere in there, but you were in that room, and you're studying on med notes and biochemistry and pharmacology, and I don't know what else, Chris. I mean, it was insane.
It was very painful. It was 2 years of complete didactic and very little interaction. So I'm glad it's much more interactive.
Yeah, and I remember thinking, I mean, it was hard, and I didn't excel quite so much in those 2 years. And then when we got into our clinical years, it was nirvana. I mean, to be able to go on rotation, oh, that was fun. So I'm glad you guys get that earlier in your experience.
And speaking of anatomy lab, you'll be happy to know that the one and only Dr. Larry Coker is still with us, running down.
Oh my gosh, that's great. That's great. What about Jack Snar? Is he still around?
He's not on the faculty. I think he's emeritus faculty at this point. We keep in touch with him on the alumni team, and obviously very well beloved.
Yeah. Well, our class always called him Snack Jar. I don't know if that was just our class or everybody, but he was Snack Jar.
That's a new one to me.
It works.
Nice.
Oh my gosh. And what are people going into now? I should know this, but I don't. I mean, is there more primary care? Is there still a big move to specialize after residency?
Yeah, I'd say everyone, not to dominate the conversation, but all the M3s and M4s I know, they're all going into specialties. And I think it probably has to do with training at like more of a tertiary care kind of like hospital. But I don't know.
Yeah, it was I think Northwestern kind of, always, that was the way it was too when I was training. It was everybody went into cardiology or something like that, but it wasn't much primary care. But yeah, it's very different in Colorado. I think we have a pretty robust primary care track. Right. I think that I'm out of time to ask you guys any more questions, but super fun to hear from you. It's really neat.
Absolutely, such a special treat. And I just want to not only thank you, Dr. Price and Dr. Thurstone, but I want to thank all the students. You really made it a special conversation. And Tina, you did a great job moderating. This is our final APF for the academic year. We'll be back with another set of 12 of them next fall. In the meantime, I hope you guys reach out to me to take advantage of our new virtual heart-to-heart program, which is the opportunity to have informal Zoom calls with alumni volunteers across the country. We started this in May for really the incoming M4s who needed it when they couldn't do rotations and needed access to doctors as they and alumni mentors as they were getting ready for residency interviews, and some of them still figuring out what specialty they want to go into. But now it's been opened up to all 4 classes, and I definitely see it as being a year-round all MD school opportunities. So I'm your guy. You need to meet a mentor in any sort of field, you just reach out to me, and I'll be happy to connect you. It's my favorite thing to do. So, thank you all so much again. Have a wonderful night.
Thank you.
Stay safe.